Hello, everyone. My name is Abigail Lopez, and on behalf of Riverside Community Health Foundation, we would like to welcome you to today's session, Patient Advocacy and Cancer Data Working Together at this year's virtual SoCal Women's Cancer Conference. We'll be selecting questions to answer during the Q&A portion of this talk, so please send us your questions via the chat feature throughout the presentation. You do not need to wait until the end to do so. If you're using a desktop or a laptop, you can find the chat box on your right-hand side, right next to the video. If you would like to interact during the session, but would prefer to be anonymous, you can leave any questions or comments in the Join the Discussion section, which can be found below the video towards the bottom of the page. If you're using a cell phone to watch the session, you can find both the chat box and also the Join the Discussion sections right below the video. If you're enjoying the session, please let us know and give us a thumbs up. If you need any support with accessing any of the talks or have any trouble throughout, please email us at terry@rchf.org. That is TERRI@rchf.org. It is now my pleasure to introduce you to Oncology Registry Manager at UVA Medical Center, Kyoka Walcott.
Thank you, Abigail. I am completely excited and over the moon to be here and to share my experience, my knowledge, and my profession with all of you. So thank you for having me again. As you mentioned, I am the Oncology Registry Manager, sometimes known as Cancer Registry Manager at University of Virginia Medical Center in Charlottesville. And prior to that, I've worked at Moffitt Cancer Center and Cancer Treatment Centers of America, UC Health, kind of a mixture of places, all in the oncology field. So I'm really excited about that. I have a total of about 17 years of oncology registry experience, and I have also a certification that I'm really excited about, John Maxwell certification in coaching, teaching, training, and speaking. So these opportunities are just right up my alley. So thank you again. Next slide is our objectives for the day. So we have 3 main objectives, and we're going to add to those along the way. But the first one is participants will be able to explain what patient advocacy is. And some of you may know that already, but I'm excited to add to your knowledge. And if you don't know what it is, I'm excited to kind of help you begin to explain and know what that is. The second is participants will be able to explain the importance of advocacy in in cancer care in particular. However, this can translate into any kind of care. If you've got diabetes, if you've got mental health issues, I mean, patient advocacy is across the gamut. So let's keep that in mind. But today we'll focus on cancer. And then last, participants will be able to explain what being an advocate for their health means. And that's really where the rubber hits the road. And so we'll go on to the next slide. So let's open up with what is a patient advocate? And I'm going to read this verbatim for the sake of the audience. And I want to also note that this definition comes directly from the National Cancer Institute website. And so you can Google patient advocate and get many descriptions that will include this, as you can see here on the screen. But this is from the National Cancer Institute. Again, we're focusing on cancer care today. So a person who helps guide a patient through the healthcare system. This includes helping through the screening, diagnosis, treatment, and follow-up of a medical condition, such as cancer. A patient advocate helps patients communicate with their healthcare providers so they get the information they need to make decisions about their healthcare. You will notice as we go through the slides and we hone in on cancer registry, you will notice some of those same words: screening, diagnosis, treatment, and follow-up of a medical condition. That is literally what cancer registrars do in their collection of data. And we'll get more into that as we go through these slides. Next slide. Patient advocates. What do they do and how can they help? Well, many things. As these two bullet points mentions, a patient advocate can help you schedule doctor's appointments, medical tests, assist with obtaining financial aid or legal aid, social support. They can help with insurance companies. They can help talk to your employers as you go through your health challenge and you want to keep your job. They can help navigate through that along with a team of others, and we'll talk more about that. Case manager and other healthcare needs. In a nutshell, the patient advocacy is someone who champions you from the beginning of your diagnosis to throughout your lifetime. Because once you have been diagnosed with cancers, many of you who are survivors or cancer patients out there, or caregivers even, you know that this diagnosis kind of sticks with you throughout your life. And that doesn't necessarily have to be a bad thing. Keep in mind that you have a team out there available to you, and it would behoove you to be sure you tap into that. You cannot go through a diagnosis like this alone, and you should not. So I encourage you to search out your patient advocate. Next slide. What are some of the questions? So as a patient and you get this diagnosis, you're completely overwhelmed. Your emotions are all over the place. You're just not sure about how you're going to take care of the kids or the bills or your job or your home or you're this or you're that. And so what kind of questions should you be asking your patient advocate? And these questions, keep in mind, you can also ask your physician and other folks on your medical team. So let's just be clear about that. But here are just some top 3 questions that you definitely want to make part of your repertoire when you are introduced or scheduled to meet your patient advocate. So one is, what resources does your hospital have in place to support me as a patient? Because it is all about you. If no one has never told you that, your healthcare is all about you. And so if you don't ask these questions, you will not know. And if you don't ask these questions, your patient advocate won't know. That encourages them to go out and find the answer, because they don't know all the answers. And that's okay. I mean, you want them to be honest, but you want them to also let you know that they are on your team, and whatever it takes, they're going to find the answer for you. So what are some of those resources? And as you can see on the slide, these are just some examples. Social worker. Through my profession, I have been fortunate to have met some social workers, one who is a very close friend of mine, nurse practitioners and physicians and rehab and you name it. But social workers are a wealth of information. I mean, they are a wealth of information and a wealth of medical talent. One of the things social workers can help you with is your disability, your short-term disability as you go through your illness. And let me tell you, that alone can stress you out, and stress is a #1 feeder for cancer. So please, let your social worker, let your patient advocate, as we're building the team, your social worker, your patient advocate, your medical physician, that team is continuing to grow. Let them help you get that done. You are not alone. That's really important for you to know. Short-term disability will save your job, and short-term disability will also allow you to keep a percentage of your income coming through. Social workers can also help with home health assistance. As a caregiver, as well as a patient, that is going to come in handy, and you do not want to take advantage. You do want to take advantage of that. Social workers can also help with therapy and other supportive care. And these are just to name a few. And your physician can also help you with these things. But again, the social worker they're trained and passionate about these areas. Other questions is about data and statistics. And that data, keep in mind, is not just for your local hospital, but also for your area, your local area, your neighborhood, your state, your country. Data is a really good partner in advocacy for your healthcare. And so where does that data come from? And we'll get more into that as we go through our slides today. But just to touch on a few, Your data comes out of your tumor boards or cancer conferences. And let me stop for a moment to kind of explain what tumor boards is and or cancer conference. Those names are used synonymously. A tumor board, if you can imagine a group of medical specialties in multiple disciplines and backgrounds in a room coming together to discuss your case and others to come up with the best treatment option for you and the best mind, body, and soul care for you. Because these groups often include, depending on the size of your hospital, depending on the ability of care, but often includes nurses, that's physician assistants, as well as nurse practitioners, as well as floor nurses. It often includes your genetic counselor, who's a really good, important piece on getting to figure out what's the best care for your particular cancer. Your medical oncologist, your radiation oncologist, your patient advocate, your radiologist. I mean, they're all sitting around a room and figuring out what's the best care because, you know, 2 heads are better than 1, 3 heads are even better, 4 and 5, etc. And so at the end of that tumor board, that usually 1-hour meeting, as they go through your slides, that includes your pathology and your film, all of your scans, and your medical record. By the end of that, they have come up with a treatment plan that best describes you. And that they take in account your religious beliefs, they take in account your personal beliefs. All those things are discussed within that hour. And so the tumor boards, cancer conferences is another great way to get information. And oftentimes that the note that they suggest is then transmitted into your medical record. So you can oftentimes see what they suggest and talked about in those meetings. Additionally, there are annual reports in your hospital, and those are usually electronic or paper form. You can ask your marketing department or your physician about that, and it'll tell you about how many breast cancer patients they've seen, prostate cancer, who the CEO is, and all those kind of things. And then there's the cancer registry. And again, we'll talk more about that. But cancer registry, in a nutshell, is the department within a facility, especially if that facility isn't accredited by the Commission on Cancer. It's a department within a facility that's required. And that department is the one that's responsible for collecting all that cancer data of every cancer patient that walks through that door. So they have a wealth of information. And then some more questions are, what are your financial options? Again, you know, do you need assistance with getting your healthcare paid for? Are there scholarships? Are there grants? Are there just other charitable things or options with Medicare, Medicaid, or your general insurance? And are there any clinical trials available? Some of you are very interested in that. And usually the clinical trial departments within a facility is attending those tumor boards. So they're right there thinking in their brains are going about what clinical trials they have for this patient, if any, and they speak up to make sure that it's known so that the patient can get enrolled and be cared for as quickly as possible. Because we all know the best care is preventative care. Next slide. Awesome. So advocating with cancer data, how can you advocate through the data capture? Well, you can advocate by, as it brings out here, that data will reveal different treatment patterns and trends and survival analysis. That data gives detailed information to the patient and to the physician about making the best and the wisest decision according to your particular cancer, your particular histology, your particular age, your particular ethnicity. I mean, cancer data is an advocate. Let's not forget that information is power. And so the more information you have, the more cancer data you have, the better decision-making you can make. Next slide. So where does this cancer data come from? Now, here's where we start talking about the cancer registry a little bit more in detail. So first and foremost, you can get data from you, the patient, right? That's where it first begins. And that data, as you come into the hospital and you tell your doctor how you've been feeling, how long you've been feeling this way, when did you notice it? What size was it? What did it feel like? You know, and then as they too ask those questions, as they're checking you out and palpating your areas of concern, and they're inputting that information into the electronic medical record system, or the EMR. And that is where the cancer registry goes into to get that information, or retrieve that information, or abstract that information into the cancer registry software. And then that goes out. That information then is required by law to be reported to the National Cancer Database, to the state cancer registry, and within your hospital as well. Sometimes the marketing department needs that data. Sometimes a physician, let's say a particular physician needs to know how well this particular chemo is doing with their patients. Cancer registry can pull some numbers and some data and help them figure that out. Other departments that may have information within your facility is the quality department. They usually collect HIPAA information and hospital policies and make sure our physicians are certified in their specialties and keeping up with their CMEs. So that's another area where you can get data from to help make better healthcare decisions. But most importantly is that electronic medical record. That's where all your labs and your billing information, your demographics, all that stuff is going in there. And the better medical, if you can have a great medical record system, that will also support and advocate for great healthcare as well. Next slide. All right, so what is a cancer registry? Well, I'm going to read this verbatim and then I'm going to get into it a little bit deeper. So cancer registries are data information systems that manage and analyze data on cancer patients and survivors. Cancer registries are maintained to ensure that health officials have accurate and timely information on cancer incidence, treatment, and survivorship. Cancer registries are classified into 3 types. You have your hospital registries, which is what we're talking about mostly today. Within your hospital, there is a cancer registry where data can be retrieved from. There's also a central registry, which is within your state, for example, where they collect population-based registries and maintain data on all cancer patients within a geographical area. And then there's special purpose registries that maintain data on a particular type of cancer, such as brain cancers or a pediatric registry, blood registries, there's trauma registries, there's burn registries. I mean, the list goes on. But in particular, these cancer registries are departments within your facility that collect all the cancer data, and that data must be accurate. And so we do that, and humans do that. It's not a computer. This actual human, like you and me, that goes into the medical record and reads through your medical record and all your outside records. We oftentimes have to call other facilities. If you've been diagnosed elsewhere and you're coming to my hospital for treatment, we reach out to that hospital or that cancer registry. Registries work among each other very well. We know how important it is to collect the data. We respect each other and we respect the accuracy, and we know that it is vital to you as a patient. And so we help each other out. So we call each other, we send out letters, and sometimes we also reach out to the patient and get information yearly as a follow-up, just to check and make sure that there's no reoccurrences, that there's no progression of disease, or that if if you've relocated and changed your physician or what hospital you're going to, we want to make sure we're keeping record of that. We want to follow you from the time of diagnosis. We're actually required to follow you from the time of diagnosis to up to the age of 95 or to the time of transition, if that's the final result. And we make sure that data is reported yearly to the National Cancer Database and monthly to our local cancer, state cancer registry. Next slide. Who collects the data? Well, who collects the data are cancer registrars. And cancer registrars, like myself, are certified tumor registrars. We literally had to take a test. Yes, a test. And that test cost us a pretty penny, depending on what your financial level is. And after studying and working within the field for at least a year, then you're qualified to sit for that exam. And it's not an easy exam. I mean, it's not the bar exam either, but it's not an easy exam. But it's when you take that test and you pass it, you have such a sense of pride of yourself. And then you're required yearly, like other professions, to keep that certification up. So we are a bit of a brainiac when it comes to cancer data. By the time we go through your chart, we have to put on that physician hat, and then sometimes that radiologist hat, sometimes that patient advocate's hat. I mean, we have to go through all of that. We're reading your path reports. We know who are the best doctors. We know who performs great surgeries. We know who has great rapport with their patients. We often get those follow-up letters back that says, Dr. Jones was the best on earth, or Dr. Jones was the worst on earth. Who do I talk to complain about him? So we are in the beginning, through the middle, and even at the end. Cancer Registry is looking at you through the electronic medical record lens and collecting your data and making sure that we are getting it accurately, and that we are getting the complete picture, so that when you take that survivorship care plan or your copies of your medical record to the next facility, physician, treatment center, it is a complete, concise, summarized record of you and your particular diagnosis and your particular histology of cancer. So back to the slide, who collects the data? Cancer registrars. We collect the data. We collect the data, the complete history, diagnosis, treatment, and health status of every cancer patient in this country. And there are cancer registries internationally as well. In most countries, actually, most countries and islands, there is a cancer registry, National Cancer Registry Association, and there's cancer registries. We come together once a year on a national level here within the United States, and once a year on an international level. So, and that's always exciting. The data provides essential information to researchers, healthcare providers, and public officials. It helps monitor the advance of cancer treatments and research, and improve cancer prevention and screening programs, which is also important. Again, the best treatment is prevention. And then this information, as well as the website where you can get additional information about cancer registries and how to become a cancer registry, what kind of data we collect, what is the test consist of, how much it costs. All of those details you can get right here from this National Cancer Registrars Association website. So jot that down for all of you out there. It's a great profession. Many people do it all through retirement. You can work from home. You can work within a hospital setting. You can travel with this as long as you have a laptop. It really is a satisfying profession. And it doesn't do too well as far as cost of living. You can make a decent cost of living as a cancer registrar. Next slide. Okay, so what does that data collection process looks like? As I mentioned in the slides before, and in the slides to come, we cancer registrars collect your cancer information from the time of diagnosis, even if it's outside of our facility or our hospital, throughout your life until you transition or reach the age of 95. And so that data is done numerically as well as in text form through coding. We have a coding manual. We have several coding manuals actually, and the rules changes all the time. We have to keep up with that. But we code that accordingly into our cancer registry software. And there are multiple cancer registry softwares out there. But that software allows us to collect that data, and then it runs edit checks on that data to make sure we're doing our work accurately. And as we send that information to the state, it also then runs an edit check through our data to make sure, again, that we are accurate, complete, and concise in our data collection. Where do we get that data from? Again, you, the patient, we get it from the medical record, which includes all of your demographic information. We collect it all: your name, your date of birth, your address, your employment, your insurance, if you have any. We collect your H&P, your history and physical. How long have you been feeling this way? Where were you diagnosed? Who's your caregiver? We sometimes have to collect information on your age at diagnosis, as well as your staging information and your workup information. Like, where did you get an x-ray? Did you get blood work? What did it say? What did that biopsy say? Where was it done? What's the results of that? Are they planning to do surgery or not? That staging, we go into, were you staged when you came in? If you weren't, we stage you as a prompt to for the physician and for the notes in our records. Until that staging comes through, we have to put in what, based on, we don't come off the top of our heads. Let's be clear, we are certified and trained in this area. We have books among books to figure this stuff out. We make sure that we go through your chart and we say the size of tumor is 3 centimeters. Go into that staging manual that's available to you as well. And we look, a 3 centimeter breast cancer is a stage what? And we code it accordingly. And we enter in text field why we staged it that way. So staging information. Treatment information. Are you receiving chemotherapy? What type of chemotherapy? How many cycles of chemotherapy? When did it start? When did it end? Radiation. Are you receiving that? Is that here or is that elsewhere? Any hormone therapy, palliative care, any of that stuff. And again, numerically and text form, we are accurately and being very diligent by collecting that data and making sure we are putting everything that's known to man, really, as far as cancer, in that abstract, so that your physician and your survivorship care plan is going to be a very powerful tool throughout your care, your journey. Next slide. How is cancer registry data used? Well, in this slide, as well as the next 3 or so slides, I'm going to show you a series of different charts and review those with you of cancer data and what that data actually looks like and where you can get that from. So how is the data used? Well, it's used by healthcare professionals, public health professionals, researchers, physicians, marketing teams, etc. Commercials, the CDC, you name it. Our data calculates cancer incidence. Cancer incidence is something that plagues the world, not just our nation. And so that data is important to get out there so that we can educate the audience, our patients, and ourselves on how to best treat our patients. It determines survival rates. Again, it talks about educational and training and screening, like events like these that you're attending today, as well as conduct research on your particular diagnosis and pathology. I mean, when you are diagnosed with cancer, those cells under that microscopes look a certain way, and it looks a certain way for a certain reason. And so we need to make sure we're capturing that. Here are 2 links that by the CDC that you can take a look at, and it really tells you how important cancer registry data is. The CDC is a fan of ours, we're happy to say. And they have many videos, this is just one, to just stress the importance and to also educate you on how that data is used. I suspect we'll have a lot of questions on this. I recently just read an article in the People magazine in this month of October that stated the number of breast cancer patient diagnosis has dropped by more than 50% due to the COVID virus. People are afraid to go to the doctors or go out in public and things like that. Again, they know that information by the data we collect. Last year, we've seen this many breast patients. This year, we're seeing this many breast patients. Well, how do we know that? Well, we got it from the cancer registry as one source of information. So again, that 50% deduction means that women may be going undiagnosed and untreated. That's a scary thing. Next slide, sorry. So this slide, as I talked about, is an example of cancer data. This is a sample, just a snapshot sample of an analytical caseload at a particular hospital that I won't mention because I didn't get permission to do so. And this is showing breast in particular. However, this cancer site table will include, at your facility, will include all sites. Every organ in place on your body from the head to your feet has a code, a numerical code, as you can see on this presentation. For breast, the numerical code is C50, and then the number after that is the subsite. C50 is the breast. The number after that is where on the breast. As we know, the breast is in 4 quadrants. That sub number after the 50 tells you where exactly. Is it upper outer, lower inner, etc. So here's an example, and I'd like to just spend a little time and break down, for instance, let's look at breast upper outer quadrant. That is C50.4. The point is missing on this slide, but it's a 0.4. So if we look at that line, reading from left to right, we will see that first line is the code, the group code. Again, C is C50, meaning breast. The 4 means the upper outer quadrant of breast. If you go through that line, you will be able to see from left to right the total amount of upper outer quadrant breast cancers in this particular facility in the year of 2018 is 343. That is more than any other quadrant, any other area of the breast. That would lead a physician or a researcher or healthcare professional to think, why is that? And then you go and you dig deeper. The next line over is the class of case. You have analytical cases and non-analytical cases. Analytical cases are cases that are treated and or diagnosed at your facility. Okay, that's what an analytical case. Those cases, we can get the complete information on the patient because that information is within our hospital. And they usually, if they're treated elsewhere and they come to our hospital to be diagnosed, they're usually bringing those outside records with them. It's all in their head. It's fresh on their mind, who they saw, where they saw it, when they were treated, where that biopsy was done, etc. So we can collect all that data, all of that. So that's what analytical cases are. Non-analytical cases are cases that are not treated or diagnosed at our facility. However, they came to our facility because they had disease progression, or they had metastatic disease, or they have a new tumor. And so they're come to see us. The next area gives you how many male or female were diagnosed with breast upper outer quadrant cancer. And then the stages, you have stage 0 through stage 4. Now, when you're staging a cancer, you're staging a cancer based on the T, N, and M. T for tumor, N for lymph nodes, and M for metastases, if there's any. So when you get that tumor information, what size, where it's located, and you get that lymph node information, are there any lymph nodes involved? If so, which lymph nodes are involved, how many? And that metastatic information, has that cancer spread? Has it spread from the breast to the liver, or from the breast to the lung, or from one quadrant to the next? Once you get all that information, you can come up with a stage. Stage 0, meaning that it's an in situ cancer. It's meaning it's non-invasive. That's good. That's good. You can go in there and the physician can, or the surgeon can kind of scoop that out, and you will be fine. Non-invasive. It hasn't gone into the tissue at all or to the lymph nodes. It's non-invasive. It's good. Stage 1, it's invasive, but not so bad. Depending on your skin has layers. So how far down did that invasion go? Stage 1. Stage 2, you can either have a tumor or not, but now you have found some lymph nodes that are involved. That's usually stage 2. Again, and none of this means good, bad, or indifferent. It just helps the physician and your care team know how to treat you, how to treat your particular cancer. And then stage 4, again, and even in a stage 2 and 3, you may not have a tumor, but there are lymph nodes involved. And so, stage 2 is usually 1 to 3 lymph nodes. Stage 4, that's 4 or more. Stage 2 is 1 to 3 lymph nodes found. Stage 3 are 4 to 9. And then stage 4, again, as I mentioned, stage 4 is that the cancer has spread to outside areas. Okay. Next slide. This is just for your knowledge. This is the National Cancer Database. The National Cancer Database, your hospital has access to. The cancer registry, the quality department, usually whoever is heads up your cancer committees has access. And you can get benchmark reports from the National Cancer Database. Based on the year of diagnosis that you're looking for, you can look at your hospital, you can look at other hospitals in the country, I'm drawing a blank, Commission on Cancer accredited hospitals. And then you can have that data be analyzed based on age or sex or race. Now, this data does take away all the patient identifiers. So that's your demographic stuff, your name, your medical record number, your social security number. It takes all that stuff out and just gives you the data. Okay, that's what the National Cancer Database, one of the many things that they can produce. And this is straight from their website. Next slide. Okay, this website is your local state of California cancer registry website where you can find some data. So write this down, and I challenge you to go out there and click around and find some data. I might be able to show that website if we have time. But this is locally for you there in California. And no matter what state you live in, you have a state cancer registry database where your statistics are out there for the public to see and view. Okay, next slide. Okay, so this is a slide from that website for your California cancer statistics. And these statistics are taken from the year of 2014. So on most of these websites, you will notice that the data has a bit of a delay. And the reason for that is, as cancer registrars, when we're collecting that data, we're trying to be as accurate and complete as possible. We cannot collect that complete data until most of the time you have completed treatment. And on average, for any cancer patient, it's going to take about 6 months on average, and sometimes longer, sometimes shorter. But it's going to take at least 6 months for you to go through that treatment cycle. And then you may need another layer of treatment after that. So you may have your first cycle included chemo, then the next cycle may be radiation. Sometimes they're given together, sometimes they're given separately. And then after both of those, you may have hormone treatment. It just depends on the type of cancer you have. Needless to say, for all of that to be done, it could take years, a year, not years. It could take at least a year. At least 6 months to a year to do that. And so that means the data that we get to report won't be able to be reported until that has been completed. So there will be a delay. I hope I explained that well. So back to the slide, your California statistics in 2014 shows your top 5 sites in males and females there in California. So if you can see in males, the top 5 are prostate, lung, colorectal, leukemia, lymphoma, and urinary bladder. Those are your top 5 sites. For females, it's breast, lung, colorectal, uterus, leukemia. But you notice, just based on this data, if we put on our analytical hats, we can come up with some similarities or some trends. We notice that male and females, their second number 1 cancer is lung. Why is that? Is there a high tobacco or chewing tobacco going on in the state of California? Why is that? Third is colorectal. Why is that? How is that? Where did we get that? I mean, all these questions come up. As you can see, these are new cases, these are deaths and existing cases. I mean, this information can really get you going, and it can really help advocate, because if this is what's going on in your state of California, then one may assume that you would know what to do for these patients who have these type of cancers in your state, because it's so common. So you've seen it a lot. Your facilities have seen it a lot. They've talked about it a lot. They've researched it a lot. There's tumor boards going on about it. So we must know, we must have some treatment or the top treatment, and we must be educated on that so that we're going to the right places to get our treatment. That's what trends can help you decide. Next slide. This slide, it also comes from that State of California statistics website. This breaks down percentage of California women aged 20 and older diagnosed with breast cancer. It breaks it down by age, race, and stage. So we can see that the stage 0, for instance, for non-Hispanic white versus stage 0 for African Americans, right? That number is different. That percentage is a little bit different. And as you go through these, you can see the ages, where what are those ages that are mostly affected, and in that age group, what is the common stage? All kinds of questions, comments, and concerns can be developed or derived from looking at data. Next slide. So in conclusion, I really hope that I have encouraged, empowered, and most of all, educated you all on the benefits of cancer data and patient advocacy working together to make healthcare treatment decisions. I mean, these are just some of the benefits. They're limitless about how you and your caregivers and your advocates and your physicians, it's just, I mean, the list can go on as far as what you can learn from the data that you're collecting in your hospitals, in your state, in your nation. So keep that in mind, please. I have a personal experience. I have been a caregiver to my mother who has died of cancer, to my grandmother who has died of cancer, to my half sister who have died of cancer. I am currently a caregiver of my living, healthy 82-year-old feisty father. And so my family and I have some experience in that. But my mom died back in 2006. She was originally diagnosed back in 1995 with breast cancer. My sister and I were young and, right around college age. And at that time, she had a lumpectomy and she had radiation and she did some oral chemo and she was doing quite fine. 10 years later, she gets diagnosed with pancreatic cancer, a total separate cancer. And she was diagnosed in June of 2005. And and then she died in December of 2005. I correct myself. It was 2005, not 2006 that she died. And in that time, back then I was in the cancer registry field for about 10 years, and mind, body, it's in soul care was in supportive care was not what it was today. So although I was in the field, kind of new, learning the way, I did not take advantage of the patient advocacy and the social worker and all these different things that were available to me, that I wished I knew then what I know now. I would definitely have employed a whole lot more people. Because I was in the field, it was the expectation that I would know all these things. Well, not always. And so although my mother had very great care and we did a great job taking care of her, and I'm happy to have been in the field, I still cannot stress making healthy treatment decisions takes teamwork. And part of that team is your patient advocate, your physician, your social worker, the data, your therapist, your home health assistant. It takes teamwork. We are part of the team. Next slide. Here are my references that I've mentioned throughout the presentation, as well as some that I encourage you to jot down and take a look and research yourself and see what's good out there as far as data for your particular cancer. It's out there. You just got to go and look. And that's it for me. Thank you. I really appreciate my time here. I hope this information has inspired and informed you and changed your life in a positive way. Thank you so much.
Thank you so much, Kyoka, for sharing your insight and knowledge about cancer registry and its role in cancer data and how it can turn and in turn influence the advocacy for the cancer community. So thank you so much. So now it's time for Q&A with questions from our audience. So our very first question is, do you have any tips on how someone can be assertive? So it's more into the individual level.
Yeah, don't take no for an answer. Don't take no for an answer. Again, as we've talked about throughout the presentation, ask questions. That's how you can be assertive. Just ask questions in whatever your comfort level is. Some of us are straight down the middle, no chaser. The rest of us are a little more timid. Pre-write down your questions, and based on this presentation that may have sparked some other questions, write those down. Take those to your next doctor's appointment. Ask to see the social worker. Ask them if they have a cancer registry. Ask questions.
Definitely very important. And something that you said also earlier in your presentation, the fact that you're not alone. You have a team there, so use them for your support and resources. So awesome, thank you so much. The next question is, how can you encourage yourself or others to advocate for your own health?
Well, listen, I, as a coach and speaker and just as a human, I know for a fact, Les Brown is one of the people in my repertoire of encouragement that I go to along with others. But he says, and I believe he may have gotten a quote from someplace else, but the major key to your success is YOU, That's the major key. So, I mean, if you don't care, if you aren't curious, if you don't ask, it's possible no one else will. It is possible no one else will, because most people are assuming that you're thinking of this stuff yourself. They don't want to overload you with things that they figure you may have been thinking about already. So be an advocate for yourself first, and then go out there and find your team.
Definitely, completely agree. And then also the simple fact that if you don't ask, we or professionals may not know what you need. So definitely speak up for your needs and advocate for your health because it is your health.
Yes.
And then lastly, the next question is, how can I improve my advocacy skills?
Again, all of everything we've already said. Research, look at those links and more. I have a link out on LinkedIn. You can reach out to me. There are books, websites, therapy. There are just, that hospital is full of certified, educated, excited, encouraged people who do this for a living and love it. Tap into it all. Tap into it all. There is no limit. There is no limit. Your survivorship care plan, if your hospital does those things, we'll sum that all up. That will also list some information and some resources for you. Your social worker is a great resource for all those things that's out there available. Yeah, it's just, do your research, ask questions, go to websites, read books. I mean, nowadays this information is free. You don't have to go to an Ivy League college. I mean, this internet stage, it's out there. Testimonies, videos, experiences.
Thank you. And yes, please make sure to look at her LinkedIn. You can find that on her speaker profile. So if you click on one of the links above that says schedule, you'll have a little drop down menu. You can click on speakers and you can find Kyoka and take a look at also her LinkedIn and other resources she may have.
Awesome.
Thank you so much, Kyoka. Do you have any other comments or any last minute thoughts?
Again, just thank you. This has been a plum pleasing pleasure. And so I hope to come again, and thank you all for being a part of this.
Thank you. Definitely. We'll definitely keep in touch. I'm going to tap into your resources and your knowledge.
Awesome.
Thank you. And to our audience, thank you so much for joining us today. It's our last day of our conference. I hope you really enjoyed all the 4 days. And if you missed any of the sessions, you can always watch those by clicking on the on-demand button at the very top link and share with your friends and family. If you want more information on the Pink Room Plays and the no-cost services that we offer, follow us on our Instagram and our Facebook. Both are at the Pink Ribbon Place, or our website, which is pink.rchf.org. So you'll be receiving an email after the conference with a survey link. So please let us know how we did, how we can improve for next year. And then also, the best part is you can have an opportunity to win some great prizes. So thank you so much again, and until next time, bye.
Bye.